Well, we presented the 5-year results of the STAMPEDE trial, and this is a study that compared bariatric surgery with very intense medical therapy to treat type 2 diabetes. So this was a randomized controlled trial with 3 arms. So 150 patients were randomized to either 2 types of surgery, the gastric bypass surgery, sleeve gastrectomy, and the 3rd arm was very intense medical treatment of type 2 diabetes. So the medical treatment was basically standard ADA guideline treatment plus some lifestyle intervention strategy plus some aggressive drug medication with the goal of adding drugs until the patient reached an A1C of 6% or less, or until they had some type of side effect from the drug. The findings at 5 years were that surgery, both surgical procedures, were much more effective in achieving the primary endpoint. And the endpoint was the success rate at reaching a very tight glycemic goal of an A1C of 6%. And that's a tight goal, recognizing the fact that at the beginning of the study, these patients generally had poor control. Their average A1C was 9%. The problem is that there has been a lot of literature to suggest that in the past, but this is a randomized controlled trial comparing surgery with essentially modern medical therapy. We measured a number of endpoint hemoglobin A1C, which is the best long-term measurement of glycemic control. We measured fasting blood sugar in these patients. We measured the medications they're on. So what's remarkable, in the surgical group, not only do they have superior glycemic control throughout the 5 years, but they were able to be weaned from a lot of their medication. So, for example, at the start of the trial, about 50% of the patients were on insulin. And the surgical patients, the vast majority were able to be weaned off insulin and other diabetic medications, yet still had much better glycemic control. This is one of the longer studies with 5-year follow-up in a randomized controlled fashion. And it's important to mention that in addition to improved blood sugar, of course, the weight improved. And the average surgical patient lost about 25 to 30% of their body weight. And the medical group, they only lost 5%. So weight loss was probably a big factor in improving their blood sugar. But at the 5-year mark, the therapeutic gap between the surgical and medical group was quite wide. It looks like it's very stable. So it's unlikely that those are going to necessarily come together in the short period. There are some studies of bariatric surgery, not randomized trials, but studies that go beyond 20 years that suggest that weight loss, for the most part, is maintained out to 20 years. Now, there will be some patients that will regain some weight, but the vast majority, if you look at the averages, the weight loss is sustained, 20 years and beyond. Yes, then there were some differences that favored the gastric bypass. For example, patients who had gastric bypass had greater weight loss. They had a greater likelihood of being weaned from or dependent on medical treatment. They also had better quality of life. We did measure quality of life as well. In our trial of 150 patients, it wasn't large enough to really look in detail at rare but serious complications. However, there were no perioperative deaths. There were some surgical complications like bowel obstruction, there were some ulcers, there were some strictures, but these were fairly infrequent and they did not result in any long-term disability. The reoperation rate over the 5 years was about 7%. So 7 out of 100 patients needed some type of reoperation, but fortunately there was no long-term disability. The cardiologists are interested because metabolic surgery can help them reduce the long-term cardiovascular morbidity of type 2 diabetes. And don't forget that type 2 diabetes is a big risk factor for cardiovascular disease. And also the endocrinologists are concerned about reducing the long-term diabetic complications such as retinopathy and nephropathy. Now we did look at that in our study. At the 5-year mark, however, there was no statistically significant difference in rates of retinopathy and nephropathy in this study, probably because of the sample size not being sufficient to show a difference. And we are joining now with 3 other sites who are combining our data. 3 sites, one from University of Pittsburgh, one from Boston, Joslin, Harvard, and also the University of Washington. And we're combining our data. We'll have a sample size of more than 300 patients that have been randomized to medical versus surgical therapy. And we hope that with this larger sample and longer follow-up, we'll be able to perhaps look at some of these important clinical endpoints, such as blindness, amputation, heart attack, and stroke. The final take-home message for clinicians who treat diabetes is that there is another powerful tool, surgery. And our study and others have shown that surgery is effective in improving blood sugar, also effective in improving other cardiovascular risk factors such as HDL cholesterol, triglycerides, reducing body weight. We also showed that other metabolic biomarkers such as C-reactive protein are improved, improving quality of life, and it's relatively safe. The perioperative risk of major morbidity and mortality is low. It's about the same risk as gallbladder surgery, much lower risk than, for example, coronary bypass surgery. So it's underutilized. Only a small percentage of patients who are eligible for surgery are getting it, and I think clinicians should be aware of this option for their patients. In some people, surgery can cure diabetes. If you use the definition of the American Diabetes Association, which means normal blood sugar on no medications for 5 years or more, and in our study, about 20% of the patients were able to basically achieve long-term remission of their diabetes, and there is no other treatment on the planet so far that has been able to show that.